Thank you. I too would like to express my gratitude to Dr. Pickering for all his contributions. In the interest of time, we'll discuss today the meningococcal B vaccine for high-risk individuals and to have a plan to have a vote. We will delay discussion of the broader use of MenB vaccines for adolescents until the June meeting. And Jessica McNeil will present.
Considerations for use of Serogroup B meningococcal vaccines in persons at increased risk. I will begin with a summary of the current meningococcal vaccination recommendations for persons at increased risk, and will then briefly review the groups at increased risk for Serogroup B meningococcal disease, the immunogenicity and safety data for the MenB vaccines, and will summarize the outcomes from the GRADE evaluation. Proposed policy option language will then be presented for a vote. Meningococcal conjugate vaccines are routinely recommended for persons over 2 months of age at increased risk for meningococcal disease, including persons with persistent complement component deficiencies, persons with anatomic or functional asplenia, microbiologists who are exposed routinely to isolates of Neisseria meningitidis, persons at risk during a community outbreak attributable to a vaccine serogroup, persons who travel to or reside in countries in which meningococcal disease is hyperendemic or epidemic, unvaccinated or incompletely vaccinated first-year college students living in residence halls, and military recruits. There are now 2 Serogroup B meningococcal vaccines licensed in the United States for use in persons 10 through 25 years of age. Trumenba is a 3-dose series and was licensed by FDA in October 2014. Bexsero is a 2-dose series and was licensed by FDA in January of 2015. Bexsero is also licensed in several other countries for use in persons over 2 months of age. The work group has been discussing a number of different options for use of MenB vaccines. To address the immediate need of protecting groups at increased risk, the work group is suggesting language today for vaccination of persons with persistent complement component deficiencies or anatomic or functional asplenia, microbiologists, and use in outbreaks response. The work group has also been reviewing available data and discussing options for broader use of MenB vaccines in adolescents and college students. Policy options for broader use of MenB vaccines will be discussed at a future meeting. The work group has discussed a number of different age group options for recommendations for persons at increased risk, including the current licensed age indication for both MenB vaccines, which includes persons 10 through 25 years. Additionally, the work group considered language for persons over 2 months of age at increased risk, as Bexsero is currently licensed for persons over age 2 months in other countries. However, data is not yet currently available for use of Trumenba in children less than 10 years of age, and the schedule and reactogenicity profile for the MenB vaccines are quite different in young children compared to adolescents. The work group plans to review the data for persons aged 2 months through 10 years and may propose expanded policy options for persons at increased risk in the future. Today, the work group will suggest language for use of MenB vaccines in persons 10 years of age and older who are at increased risk for meningococcal disease. This goes beyond the licensed age indication, but the work group is comfortable that there are no theoretical differences in safety for those over 25 years of age compared to those 10 through 25 years of age. Next, I will review the groups at increased risk for Serogroup B meningococcal disease. Persistent or genetic deficiencies in the complement pathway are well known to increase risk for meningococcal disease. These deficiencies are rare and only affect about 0.03% of the U.S. population. Individuals with persistent complement component deficiencies are at up to 10,000-fold increased risk for developing meningococcal disease and often develop recurrent infections. Eculizumab is a monoclonal antibody that is approved for treatment of atypical hemolytic uremic syndrome and paroxysmal nocturnal hemoglobinuria. It functionally creates a complement deficiency by binding to C5 and inhibiting the terminal portion of the complement cascade. Several individuals in the clinical trials for eculizumab have reportedly developed meningococcal infections despite prior vaccination with conjugate vaccine. Persons being treated with eculizumab were not explicitly included in the conjugate vaccine recommendations. However, meningococcal vaccination is required for persons prior to treatment. Persons with functional or anatomic asplenia also appear to be at increased risk for meningococcal disease. However, the data are less compelling than the risk for pneumococcal disease. This group includes persons with sickle cell disease, which affects about 90 to 100,000 persons of all ages in the U.S. In asplenic persons, the case fatality ratio is also elevated for meningococcal disease, and it has been demonstrated that asplenics have a significantly lower response to one dose of MenC or meningococcal C vaccine. Microbiologists who work with Neisseria meningitidis are also at increased risk for meningococcal disease. In a review by Sevar et al., 16 cases were reported worldwide between 1985 and 2001. All occurred among clinical microbiologists and medical microbiology labs. 7 were due to serogroup C and 9 serogroup B. None of the cases in the review occurred in persons working in hematology, chemistry, or research labs. 8 of the 16 cases were fatal, and 15 were microbiologists who had performed strain manipulation on an open lab bench. Since this review, there have been 6 additional cases of meningococcal disease reported in microbiologists. 2 occurred in the U.S., and 1 each in New Zealand, France, Sweden, and Argentina. And these cases included cases in industry and research microbiologists. In the Sevar paper, they estimated an attack rate of 13 per 100,000 among microbiologists who work with Neisseria meningitidis. The high case fatality ratio observed among microbiologists who have developed meningococcal infections is likely because of increased exposure to high concentrations of organisms and highly virulent strains. The majority of cases have occurred among clinical microbiologists who are not using respiratory protection at the time of exposure. The final group includes persons at risk because of a serogroup B meningococcal disease outbreak. Fortunately, meningococcal outbreaks are rare and cause only about 2 to 3% of U.S. cases. However, several serogroup B clusters and outbreaks have been reported on college campuses during the last several years. In 2 of these recent outbreaks, students were estimated to be at 200 to 1,400-fold increased risk for meningococcal disease during the outbreak period. In the recently published guidance for serogroup B meningococcal outbreaks in institutional settings, the thresholds for considering vaccination were defined as 2 cases in institutions of less than 5,000 persons and 3 cases in institutions with more than 5,000 persons. During the first 2 months of 2015, 2 outbreaks of serogroup B meningococcal disease have been reported on college campuses in the United States. 2 cases occurred among students at a Rhode Island college with 4,500 students. A vaccination campaign was held in response to the cases using Trumenba, and approximately 98% of the target population received dose 1. 4 cases of serogroup B meningococcal disease have been reported at an Oregon university with 25,000 students, including 1 death. 2 of the 4 cases were epidemiologically linked, but were not close contacts of one another. Planning is currently underway for a MenB mass vaccination campaign, which is scheduled to begin on Monday. Additional sporadic cases of serogroup B meningococcal disease in college students have also been reported to the CDC this winter. This table summarizes the risk groups we have just gone through and also includes the available data on cases that have occurred in each of the risk groups. Approximately 300 to 350,000 individuals fall into these groups. Although only a handful of cases have been documented in ABCs or the published literature, these groups are well known to be at increased risk for meningococcal infection and are currently recommended to be vaccinated with meningococcal vaccine, but remain at risk for serogroup B meningococcal disease. There are 3 groups that are included in the current conjugate vaccine recommendations, but are not proposed to be included for MenB. First-year college students living in residence halls are not included because they are being considered in the broader adolescent and college student policy options. Travelers are also not being considered because their risk is primarily due to serogroups other than B. Finally, military recruits are not being considered because the current serogroup B epidemiology in the military is similar to the U.S. population, and DoD sets its own vaccination policies. I will now summarize the available immunogenicity and safety data. Both of the MenB vaccines have a demonstrated immune response in the general adolescent population. Nearly all adolescents in clinical trials achieved protective antibody titers after either 3 doses of Trumenba or 2 doses of Bexsero. For Bexsero, response rates were somewhat lower in a small study done among U.S. and Polish adolescents. However, it is important to remember that immunogenicity data are not directly comparable for Trumenba and Bexsero, in part because the primary endpoints differed for each of the vaccines. Immunogenicity data is not currently available from persons in most of the groups at increased risk, although there are some limited data available for use in laboratory workers. And finally, only limited short-term antibody persistence data is available for Bexsero. Persistence data for Trumenba should be forthcoming shortly, and this antibody persistence data will be important for informing booster recommendations for these groups at increased risk in the future. There are still several pieces of additional data that are needed for both vaccines to inform policy decisions. This includes immunogenicity against additional strains to evaluate breadth of coverage, antibody persistence data, safety and immunogenicity data for concomitant vaccination, groups at increased risk, and for other age groups, as well as additional safety data. A number of these studies are ongoing, and data will be reviewed by the work group as it becomes available. Since October, new data on the safety and immunogenicity of concomitant administration and the safety and tolerability of Trumenba have become available. A detailed description of the newly available data for Trumenba was provided to the voting members of ACIP, and a summary of that data is provided here. Safety and immunogenicity of concomitant administration of Trumenba with MenACWY and Adacil was evaluated, and it was demonstrated that local and systemic reactogenicity profiles were similar when Trumenba was administered alone or concomitantly with the other vaccines. In addition, non-inferior immune responses to all Tdap and MenACWY antigens and the MenB test strains were seen. In a large-scale safety study which evaluated the safety and tolerability of Trumenba, the safety profile observed was consistent with studies that supported licensure. There are limited plans by both manufacturers to collect immunogenicity data from persons in the groups at increased risk. A small immunogenicity study is currently underway for persons 2 through 17 years of age with complement component deficiencies and Asplenia for Bexsero. Data from this study is anticipated to be available in 2016. In addition, there are small studies currently ongoing for both Trumenba and Bexsero in laboratory workers. MenB vaccines are more reactogenic than other vaccines given during adolescence. However, the majority of local and systemic reactions to the MenB vaccines are mild to moderate in severity and transient, with the most common adverse event reported being pain at the injection site. Serious adverse reactions are rare, and rates are similar between vaccine recipients and controls in the clinical trials. Safety data specific to the groups at increased risks are not currently available, but are anticipated to be similar to the general population. There is some limited experience with safety of MenB vaccines outside of clinical trials. Most of our experience is with Bexsero, which was administered to approximately 17,000 persons vaccinated under an expanded access IND program for outbreak response at 2 U.S. universities, and over 40,000 persons vaccinated in a regional public health program in Quebec. No concerning patterns among adverse events were observed following any of the vaccination programs. For Trumenba, there is no post-licensure data currently available, but our understanding is there is safety data being collected for Trumenba in conjunction with the 2 current outbreak responses in Rhode Island and Oregon. The work group also reviewed data on theoretical concerns from mouse models about the potential development of autoimmune disorders following MenB vaccination. FDA also reviewed these data, and they did not observe any differences in the rate of autoimmune disorders between vaccine recipients and controls in the safety studies that supported licensure. Post-licensure safety surveillance will need to be conducted to detect any potential safety signals. However, it will require a large number of doses to be administered to detect any potential safety signals in VSD. In the meantime, passive reports to VAERS will be monitored. I will now provide a brief summary of the grade evaluation outcomes. The first step in the grade process is to formulate the study questions. The following study questions were agreed on by the meningococcal work group. However, today we will focus only on the last 2 questions. Should MenB vaccine be administered routinely to all persons at increased risk for Serogroup B meningococcal disease and persons at increased risk for Serogroup B disease because of an outbreak? This slide summarizes the outcomes that were ranked as critical for each question by the meningococcal work group. The first 4 outcomes cannot be assessed using grades since they are surveillance data. These outcomes were evaluated using a modified assessment, and the last 3 outcomes were assessed using grade. In grade, all of the available data for each outcome are evaluated on these 6 criteria to determine whether the overall evidence type is moved up or down and a final evidence type is assigned. Given our time constraints today, I will only review the available data that was used to assess the benefits and harms for each vaccine and the final evidence type assigned to each MenB vaccine for use in persons at increased risk and in outbreak settings. A copy of the full presentation for the grade evaluation is provided in the ACIP members' binders. For Bexsero, a total of 6 studies were reviewed, 2 open-label studies, and 4 randomized controlled trials. The majority of the studies assessed several outcomes. 4 of the studies have been published. However, we also used data from additional unpublished studies. In addition, safety data from 3 vaccination campaigns were reviewed for serious adverse events. For Trumenba, a total of 8 studies were reviewed, 3 open-label studies, and 6 randomized controlled trials. The majority of the studies assessed several outcomes. Results of 3 of the studies have been published. However, we also used additional unpublished data. Antibody persistence data are not yet available for Trumenba, so they were not assessed in this evaluation. We graded the overall evidence type for use of Bexsero among persons at increased risk for serogroup B meningococcal disease as type 3, and among outbreak at-risk populations as type 2. We also graded the overall evidence type for use of Trumenba among persons at increased risk for MenB disease as type 3, and among outbreak response populations as type 2. Based on the available data and evidence reviewed, the work group supports routine vaccination of persons at increased risk for meningococcal disease for several reasons, including the demonstrated disease risk in these specific risk groups, and that these groups are currently recommended to be vaccinated with MenACWY conjugate vaccines. Additionally, there's demonstrated immune response to MenB vaccine in the general adolescent population, and there are no theoretical safety concerns for persons over 25 years of age from vaccination as compared to persons 10 through 25 years of age. The work group also supports harmonization of the current MenACWY conjugate vaccine recommendations with the proposed MenB language in 2 areas where the language differs. First, use of eculizumab will be explicitly included as an indication for vaccination with MenACWY conjugate vaccine. Secondly, the wording for the use in outbreaks will be aligned with the proposed wording for MenB vaccines to read, persons identified to be at increased risk because of a meningococcal disease outbreak attributable to serogroups A, C, W, or Y. The 2 sets of recommendations would still differ for certain special populations, including travelers, first-year students living in residence halls, and military recruits, who are not included in the proposed MenB language. The work group's proposed language for use of MenB vaccines in persons at increased risk is as follows. A serogroup B meningococcal vaccine series should be administered to persons over 10 years of age at increased risk for meningococcal disease. This is a Category A or routine recommendation, includes persons with persistent complement component deficiencies, persons with anatomic or functional asplenia, microbiologists routinely exposed to isolates of Neisseria meningitidis, and persons identified to be at increased risk because of a serogroup B meningococcal disease outbreak. In addition, the following guidance for use is proposed. Depending on the MenB product used, a complete 2 or 3 dose series of vaccine is required for protection from serogroup B meningococcal disease. The same vaccine product should be used for all doses, and no product preference is to be stated. I also wanted to thank the members of the ACIP-Meningococcal work group for the dedication and thoughtful discussions over the last several months as we have quickly worked through a review of the available evidence for these new MenB vaccines. And now I'm happy to take any questions. Thank you.
Thank you. Any questions? Yeah, Dr. Rengold.
So Jessica, I just want to make sure I understand. I know that in terms of broader use of the vaccine, we'll be revisiting that at a future meeting. Mm-hmm. But did I, in terms of the slide about the differences between the quadrivalent ACYW135 and the B vaccine, recognizing that the military sets its own vaccination policy, is it generally envisioned that in terms of the other differences that would be there between use of the B vaccine and use of the quadrivalent in terms of travelers and college students, whatever, that unless those are considered for the broader use, that those would remain differences between how these 2 vaccines are used?
Yes, and so the adolescents and college students will be considered hopefully in June as part of the broader recommendations, but there would be a difference for travelers in the military. That would remain.
And I'm just providing a reminder to speak relatively slowly for our translation. Dr. Herman.
I'm just wondering if the committee is also going to look at the use of meningococcal vaccines, both B and ACWY, for infants. Affordable Care Act requires that Category A and B recommendations be covered, and I'm just wondering if the committee is planning to discuss vaccine use in infants.
You wanna- Go ahead.
Yes, we intend to look at the ACWY use in infants in our future deliberations.
Dr. Sawyer.
Perhaps I missed it. Could you clarify why the use for high risks is starting at age 10 as opposed to younger age, since one of the vaccines is licensed lower than that?
So currently in the US, the minimum age is 10 years of age for licensure. Bexsero is licensed down to 2 months of age in other countries, and I think the work group will eventually go back and look at that, but for right now, we just wanted to propose a recommendation for 10 years and older.
Dr. Harrison.
I had two questions. So what is being done specifically to monitor safety in the context of the use of these vaccines during outbreaks? And also, what is DOD using in terms of, doing in terms of these two vaccines?
So when the vaccine was used under an IND, as part of the IND, we did specific safety follow-up. And from what I understand, that's also being done for Trumenba in these two current outbreaks where it's being used, although CDC is not involved in that. And I'm not sure what the military does in terms of safety follow-up.
In terms of I believe the question was, what are they doing in terms of recommendations for? Yeah. So the ACWY is currently being administered, and then the B, the Joint Preventative Medicine Working Group, met last month to discuss it. And at this point, they don't think there's an indication for putting that into the recruit population.
Thank you. Yes, Dr. Dushin.
Thank you, Jeff Duchin from NACHO. Two questions. One is, will the threshold for vaccination for use of the Serogroup B vaccine, as it currently is stated for the IND, will stay the same for the vaccine if the vote is taken to approve the use of that vaccine in outbreak settings? And secondly, what's known about the impact of the vaccine on carriage?
So for your first question, so for the current outbreaks that we've been experiencing, we have continued to use the thresholds that were set up for the use of MenB vaccines in an institutional setting under an IND. So I think we would continue to use those in the near term. We are planning to go back and review the entire outbreak guidelines, and hopefully we'll present those in either October or February of the following October and February meetings. Carriage, still not a lot known, but we are currently conducting or starting to do carriage studies at some of these universities that are experiencing outbreaks right now. So hopefully we will have some more data for you, either in June or following meetings.
Other questions or comment? If there are no questions from the ACIP members, I think Dr. Mary Ferris is signed up. And as she comes to the microphone, we're going to limit the public comment to two here, dealing particularly with the high-risk recommendations. We have a number of other people and also letters on a generic use or a universal use for meningococcal B vaccine that I'm going to put at the very end during the public comment period. So thank you, Dr. Harris.
Thank you. I'm Dr. Mary Ferris. I'm from the University of California, Santa Barbara. I'm the student health director there. And we have a campus of 30,000 students, faculty, and staff. In November 2013, our campus community was devastated by an outbreak of 4 cases of meningococcal serogroup B disease within a 10-day period. And it resulted in life-threatening complications to our first case of a 19-year-old lacrosse team member who suffered amputations of both legs and has extensive skin grafts and scarring, but did survive. So I know you're aware of the devastating consequences of this terrible disease, but you may not know the impact it has on a university when an outbreak occurs. National news outlets camped out on the campus. There was widespread fear and even panic among the students, faculty, staff, and the surrounding city. The local school district initially prohibited our student teachers from their sites. Parents drove in to take their children back home. Our campus child care center refused to have the student volunteers there. Parents demanded we close the campus, did not want their students to come home for Thanksgiving holiday. It was really terrible for all of us, as you can imagine. Our local public health department and the CDC helped us and established special phone lines to handle the high volume of incoming distress calls. And we greatly appreciate all the help they gave us. And as you know, we were able to obtain the MenB vaccine through a special FDA approval with the assistance of the CDC. But we would much rather have preferred to avoid this disaster completely by protecting our students in advance with a vaccine that covers MenB. So we're glad to have your approval of the vaccine for outbreak settings, but we think that if we would benefit even more if our students came to campus already protected by the vaccine. Outbreaks will happen again, and as you're hearing, it's currently going on at the University of Oregon, and they're struggling to find a source to pay for those vaccines. Even one case in a college setting has major repercussions on the institution, and most colleges will not have the resources to pay for vaccines when these outbreaks occur. We need the ACIP to establish MenB vaccine as part of routine adolescent immunizations so that our entering students can be protected before they arrive on campus and are exposed to meningococcus, not just after an outbreak occurs. We also can benefit from your recommendation for pre-entry vaccination so that we can enforce that in our entry immunization requirements before students even get to campus. The majority of our students are first-generation college students coming from low-income families and do not have the ability to afford this vaccine unless it's covered by health insurance, which, as you know, follows your recommendations. So thank you for allowing me to speak, and I sincerely hope you'll consider the impact of this disease on both the individuals and our colleges and universities when you make your decisions. Thank you.
Thank you, Dr. Ferris. And we also have Seth Ginsburg signed up, and from the Global Healthy Living Foundation. And if you can state any conflicts of interest, and we're trying to just keep the comments as brief as we can, so thank you so much.
Thank you. Hello, my name is Seth Ginsburg. I'm the co-founder of the Global Healthy Living Foundation. I have no disclosures to make today. GHLF receives funding through grants and partnerships with industry, private foundations, as well as the government. And I'm here today on behalf of Dr. Neil Raceman, who was here down from Columbus yesterday and unfortunately needed to return to an urgent issue back at home. So instead, I'll read his brief comments here, and I will not attempt his Boston accent. My name is Neil Raceman. In 2005, I was the father of 2. Today, I am the father of 1. On the morning of September 27, my youngest, my son Isaac, woke with a headache and was dead of meningitis by 4:30 the same day. I found his body. He had less than 12 hours from the time he told us he had a headache until he died, and a vaccine would have prevented his death. It's an epidemiological story you all know too well, but it's a personal story I never wanted to know. And today I am here as a spokesperson for the Global Healthy Living Foundation, and together we are asking this committee to endorse the FDA labeling recommendation, which is for immunization to prevent invasive disease caused by Neisseria meningitis serogroup B for individuals 10 through 25 years of age. My words here today and your committee meeting could not come at a more immediate time. As you know, 8 days ago, Lauren Jones, a student at the University of Oregon, added her name to the list of those who have died of meningitis. And just 3 days ago, a UC Davis student was diagnosed with meningitis. And at the University of Oregon, students who have had the money will be able to get the vaccine for meningitis B, and those who do not will remain exposed to its ravages. Since the FDA approved the vaccine for meningitis strain B in November of 2014, people have died. Did they die because the ACIP didn't act? Perhaps. Although the vaccine was available to those who could afford to pay for it without your recommendation, as you know, insurance companies and Medicaid won't cover the cost. It's not difficult to conclude that informed people with the money to pay for the vaccine have lived, and those who can't afford it or don't know about it have died. This is counter to everything the ACIP, the CDC, the FDA, and of course the NIH stand for. So your endorsement vote for the FDA recommendation would realign this committee with its mission and with the values and expectations of parents with college-age children. We expect the government to tell us when the health of our children is in danger and then help us decide what to do about it. Because meningitis is nearly always fatal, the low numbers of people affected mask the toll these cases take on families, such as mine, and on our communities. My job today is to help you understand the depth of the emptiness that we parents feel every day and the heartache we feel for those parents who are about to join our ranks, the ranks of families minus one. Please act so other young people and their families are not so violently affected by meningitis. Please act so there are no more Isaacs and Laurens. Thank you very much.
And thank you very much, Mr. Ginsburg. I'm going to see if there's any additional comment or question around the table here. Yes, is Dr. Evans? Even.
I just wanted to speak on behalf of the American College Health Association, who are very aware of the devastating physical and emotional impact of meningococcal disease on the individual college student and their families, and the campus community, and sporadic and outbreaks, as have been eloquently described. The American College Health Association is committed to promoting implementation of CDC's immunization recommendations on college campuses, including pre-matriculation MCV4, and now that the MenB vaccines are licensed and MenB cases continue to arise, ACHA appreciates being involved in the ongoing discussion regarding use in outbreaks and appreciates the impact this guidance will have in promptly responding to this challenging situation, and also supports prompt deliberations and an expeditious decision regarding the general recommendations for MenB vaccines. So information will be available to parents, families, students, and campuses for the students entering in fall 2015. Thanks.
And thank you. Other questions around the table? And if none, do we have a motion to consider this recommendation?
So moved.
So the motion by Dr. Romero, is there a second? Yes, Dr. Kemp. Okay. Dr. Kemp, yeah, I didn't say it loud enough. So, other discussion? Seeing none, Dr. Bocchini, we can start a vote with you, and we will go to your left, which is Dr. Riley.
Bocchini, yes.
Riley, yes.
Camp, yes.
Karen, yes.
Belongia, yes.
Harrison, yes.
Harriman, yes.
Romero, yes.
Rubin, yes.
Bennett, yes.
Kempty, yes.
Pellegrini, yes.
Reingold, yes.
Camposalco, yes.
Vasquez, yes.
And the motion passes unanimously, 15 votes for. And then I think just in the spirit of full disclosure, coming up for the June meeting, we'll be discussing recommendations for a more universal recommendation. That being said, we have to couple this, I believe, with a VFC resolution. And so I believe Dr. Santoli. And again, the process by which we vote on the VFC resolution also allows contracts to be started between CDC and the manufacturers, and also allows this to come onto the VFC for public payment.
Jeannie, maybe you can just read the slide if you have your notes.
Sure. The purpose of the resolution, there's two parts. There's two parts in this resolution now, a meningococcal conjugate vaccine section, which is separate from the Serogroup B section. Overall, the purpose of the revision is to update the resolution, number one, to clarify the wording about the eligible groups for meningococcal conjugate vaccines. Number two, to streamline the schedule and interval information for meningococcal conjugate vaccines by incorporating links to published documents. And number three, to add the meningococcal Serogroup B vaccines recently licensed for use. So there's several changes. And I'll begin to read through those. I think it's a little bit complicated to read through that, but I can do that. So for the...
I don't mean to interrupt Dr. Santoli, but all the members do have the printed slides in front of them on their handouts.
So one thing that's, well, good, it's coming up because you can't see the yellow font for the first part in your black and white document. So we'll just whip through to where I am. So for the meningococcal conjugate vaccines, there were some minor changes to the wording that'll produce synchrony between the various ways that the high-risk groups are described. That's shown here in yellow. I'll give people a chance to look at that rather than reading through it. But the yellow is what's the new wording, and the white is the wording that's there now. I'll move on to the next slide. Again, here just some pretty minor clarifications to the wording that describes the eligible groups, and it is in parallel to the Serogroup B eligible groups, some of the wording there. In terms of the schedule, you may recall there was a very complicated table that we had in the VFC resolution. This just refers to the published recommendations for information about the specific schedule and intervals for these vaccines. And then there are no changes to the contraindications and precautions reference. Now for the Serogroup B meningococcal vaccines for the eligible groups. Again, this mirrors what you voted on a few moments ago. This is the schedule and intervals for the two vaccines. And just noting that using brand names here is not intended to preclude the use of other vaccines where appropriate. And then the recommended dosages, we refer to package inserts, and the contraindications and precautions, we refer to package inserts as well, providing a link. And then just at the end of all the resolutions, we note that when there are published recommendations, we will update the resolutions to point to more detailed information in the ACIP recommendations themselves. So that covers the update to the VFC resolution for meningococcal vaccines.
Are there any questions for clarification from Dr. Santoli? Dr. Bikini.
Just continue slide number 3, the meningococcal conjugate vaccines, Ultra Group 2. Isn't the HibMenCY not a travel vaccine, so it would not be recommended for children traveling because it doesn't have A? Isn't that?
Well, and I think that, so those are the eligible groups. The specifics about that, which had been included in the VFC resolution in the table, are now here. We could amend the eligible group section to make that more clear.
Okay.
And other questions? Do we have a motion for the VFC resolution? And Dr. Harrison. And a second, I see Ms. Pellegrini. Further discussion? And seeing none, we can start with Dr. Harriman and go to your right, which will be Dr. Harrison.
Harriman, yes.
Harrison, yes.
Belongia, yes.
Karen, yes.
Camp, yes.
Riley, yes.
Bocchini, yes.
Vasquez, yes.
Campus Alcohol, yes.
Reingold, yes.
Pellegrini, yes.
Tempte, yes.
Bennett, yes.
Rubin, yes.
Romero, yes.
And the VFC resolution passes again unanimously, 15 votes for. So I thank the meningococcal work group for a very succinct presentation.